Good evening, ladies and gentlemen. My name's Professor Andrew Blenire. I'm the Dean of Translational and Clinical Research here at the Faculty of Medical Sciences at the University, and it's my pleasure and honour to be able to welcome you and our speaker to today's Insight lecture. I've been asked to give the normal health and safety announcement, that there will be no expected fire alarms, so if we do hear any alarms going off, we will have to leave, and the team here will be available to direct people should that be the case, but hopefully that won't be. You will hopefully have seen or noticed on the advertising information for this evening's lecture that this is actually a named lecture. It's the Albert Latner Memorial Lecture in Clinical Biochemistry. So I thought before I introduce our speaker for this evening, I would just say a few words about Professor Latner and who he was. I understand that actually some of his PhD students and colleagues may actually be in the audience. There's at least one at the front here. So we have some linkage back into the past. So Professor Latner was a clinical biochemist, trained and originally worked in Newcastle for many years, I think for the majority of his career, in fact, from the end of the Second World War right through to when he retired. He was originally in the Royal Victoria Infirmary and working in King's College, which was part of Durham University at the time, and then became Professor of Clinical Biochemistry in the medical faculty within Newcastle University when that medical faculty was inaugurated. He was involved in trying to understand large molecules and proteins and the effects that they have in the human body and how you could use those in a diagnostic sense, and was very involved in developing technologies such as gel electrophoresis and other techniques associated with that, which are absolutely fundamental to any kind of bioscience lab. And anybody that has done any work in biosciences will be familiar with those techniques. So there was a lot of really innovative and important work that was done by Professor Latner. He was also a very well-respected teacher, inaugurated a master's course in clinical biochemistry in the university back in the early 1960s, I think that probably was. He researched, taught, and was a clinician in and around Newcastle until he retired in 1978, and he died in 1992, and after which a named lecture in his honour was inaugurated, and it is that lecture that we are having today. So, let's move on and actually introduce today's speaker, who is Professor Paul Collinson. He has an interest in clinical things, but also in sub-aqua things, which you'll see from, I don't know whether he'll say much about that, but it's obviously a clear passion of his. He is Professor of, or was, is now, I understand, Emeritus Professor of Cardiovascular Biomarkers. The title, I think, says it all. He's been interested in how you understand or make markers of cardiac disease, how you evaluate those and use that to understand what is happening in a patient and how you treat them. He has been a member of the expert advisory group for the National Institute for Health and Clinical Excellence, NICE, around cardiac biomarkers, so has been influential in the way that patients are treated around the country. He's published over 280 papers, so he's very well published, including book chapters and review articles. So, without saying any further, I'd like to introduce Paul to give his presentation based on his title of What is a Heart Attack and How do we detect them?
Well, thank you very much for the very kind introduction. It's a very great pleasure to be in Newcastle giving this lecture. And my granddad, who was a miner at Herrington Colliery, would be delighted to see me here today. And my mum was very cross that she couldn't come, but unfortunately she's 91 and she's not as mobile as she used to be. But I told her you'll be able to hear it because they're recording it. Right, okay. So I was given the title of What is a Heart Attack and how can we measure it? And I thought, though, before I do that, I'm going to I'm going to tear aside the mythology of medicine for you and reveal to you some choice secrets. So this is a short history of heart attack from Jane Austen to the present day. So this is the mysteries. Now, I'm a great fan of the Patrick O'Brien books, and this is, I think, a great remark. You can tell when a doctor coves adrift because he starts talking Latin. And this is just to give you an example. If you have a dermatitis ichthyosis rubrum, you've got, your doctor must be very clever, but he's actually told you you've got an itchy red rash. But it's much better in Latin and often costs more. And we use lots of abbreviations and difficult words because doctors don't speak Latin. That's confined now to certain buffoons in a certain place in London. Don't quote me. So what I will do throughout the lecture is that I will use medical terms, but I hopefully will define them as we go. So, this is in the beginning, there was death. Death is still with us, of course. And death said, you've had a heart attack, now you must come with me. That was it. That was all that happened, you see. And so basically, that's where we are. So in the 1800s, if you had a coronary thrombosis, a blockage of a blood vessel, it was recognised as a cause of death, but well, you've died, and that's it, really. And they were doing a bit of experimental science by that point, and they did notice that if you took a poor unsuspecting animal and tied off an artery, then actually it would die. I don't recommend doing this at home. And that some post-mortem studies done, and they showed that a blood clot in the coronary artery was present in some cases of sudden death. So basically, if you're a doctor in the 1800s and someone had a heart attack, they died. So it's considered to be an immediately fatal event. And that's really how things stuck. And then a very astute American physician called James Herrick in 1912 pointed out that actually people can have heart attacks and not die. And he said, we've got people who get chest pain, and that's angina, which is Latin for I've got chest pain. Or we've got myocardial infarction, a heart attack, and they are different. And not only that, you don't die necessarily. This was a revelation, right? This is an absolute revelation. People don't always die of heart attacks. It's good. You know, medicine moves in increments, slowly. And this actually is a copy of his article, which was published in the Journal of the American Medical Association in 1912. And it's quite funny. It really starts with obstruction of a coronary artery of any of its lower branches, long regarded as a serious accident. And then he goes on to discuss why it's actually not necessarily the case. So this was the first step towards the road of enlightenment. And he made a very prophetic statement. You'll see why later on. The hope for the damaged myocardium lies in the direction of securing a supply of blood through friendly neighbouring vessels so as to restore as possible functional integrity. What he was saying was, well, if you blocked off an artery, it'd be a good idea if you unblock it somehow. So this is good. So, what happens? Well, not a lot. Everything goes very quiet for about 74 years. There's a lot of argument about, is there a clot? Isn't there a clot? Does it matter? No, it doesn't. Yes, it does. No, it doesn't. And basically all you did with someone who had a heart attack was you put to bed and told them to get up and not mobilise too quickly and don't indulge in strenuous exercise. That was how medicine was when I started. That when I was a house officer, someone who came in with a heart attack, we put them to bed for 10 days and we got them up. And at that point, no one believed in this cholesterol nonsense. That was all rubbish, you know. Good fry up, good for you, good for your arteries. And you could smoke. Doctors endorsed it. And if you've seen Mad Men, you'll know what I mean. The only real change was that Desmond Julian published a paper in the Lancet when he was a registrar, no less, which was quite a junior grade in the hierarchy. He became a professor at a very early age, I might add, pointing out if you actually put people with heart attacks in the same place, then they've got less chance of dying because you can resuscitate them. And there wasn't really much going on. There were a few studies, people were sticking clot-busting drugs down arteries, and it was published in rather rare journals, like you see Therapeutic Archive, or this insignificant publication that arises from Boston in America, the New England Journal of Medicine. So, what about biomarkers, the tests for heart attack? So, they are sort of appearing in this timeline of development. So the question, of course, is what is a biomarker? Now, this is the definition of a biomarker from the American Food and Drug Administration, the FDA, which is a defined characteristic measured as an indicator of normal biological processes, pathogenic processes, a response to exposure intervention, including therapeutic interventions. That basically means just about anything you can measure, doing anything at any time. And a cardiac biomarker, you can pragmatically consider it's a molecule measured in the blood, which indicates cardiac damage or dysfunction. In other words, you've damaged your heart muscle or it's not working properly. So, first biomarker actually, which got into routine clinical use, is the electrocardiogram, the ECG. And it was actually first developed by a chap called William Einthoven. And if any of you have a medical background, you will have had to wrestle with something called Einthoven's triangle, which actually caused us all to gibber quietly when we were medical students. Anyway, he won the Nobel Prize for developing the ECG, which was actually very good. And Thomas Lewis looked at this in published it in the British Medical Journal in 1912. You can actually look at the original article online. And it really became apparent the ECG was quite a useful little test in people who might have heart attacks. And in fact, it's stood the test of time. We use it today. And it's essential to the diagnosis of myocardial infarction because we define myocardial infarction, heart attacks, into two types. There are those that you can actually just do an ECG on somebody and you make the diagnosis, and we call that an ST elevation myocardial infarction or a STEMI. You see where we're starting to put these lovely words in. So you can talk over somebody, and I think he's got a STEMI, and there might be some J-point depression as well, but I mean, we should do something, and you're going, what are they talking about? So that's another clue for you. And if the ECG doesn't work, we're looking at what's called a non-ST elevation myocardial infarction, which we abbreviate to an NSTEMI, or not a STEMI, basically. So ECG is good. All right, well, I'm a biochemist. I like blood tests. So what about blood tests for diagnosing heart attacks? Well, blood tests come in a variety of shapes and forms, and the simplest for tests are the ones which just say, are you well or ill? And these actually go back a long way. And the first are you well or ill test was actually to do a blood count and count how many cells there were in the blood. And it was noticed fairly early on that, in fact, if you'd had a heart attack, your white count went up. And it went up about a day or two later. So if somebody came in and you weren't sure, you'd do a white count a couple of days later, and if it had gone up, so that must have been a heart attack then. Jolly good. There's also this wonderful test, the erythrocyte sedimentation rate, and this will really restore your faith in science, because what you do to measure an ESR is you get some blood off somebody, you mix it with an anticoagulant so it doesn't clot, you put it in a tube and watch how quickly it falls. You could do that one at home if you really wanted to. And this was noted that it's basically a test to say, are you got the inflammation around? And this other one, CRP, is a marker of inflammation. And it's quite interesting to realise that people were talking about CRP in 1957 in relation to heart disease, whereas when it was published about 15 years ago, the guy who started talking about it then got on the front cover of Time magazine So, you know, things are rediscovered, not necessarily discovered. So, what is a cardiac biomarker and how does it work? Well, what we're interested in is stuff that will get into the blood that we can measure when someone has had a heart attack. So this, at the top there, I'm going to have this point. No. Uh-huh. That's a normal heart cell, right? And it's got, oops. All right. That's the trouble with these things. And it's got bits. Now those are intracellular enzymes, and they're the sort of machinery that powers the heart cells, so they make energy basically. And it's got these sort of bits inside, which are the heart muscle fibres. Right? Now they're the things that actually make your heart contract and relax. And when it's a happy cell, it's busy contracting and relaxing and pumping blood around your body and keeping you alive. But if it gets a bit dicky, it's not very happy, there's not enough blood supply, or maybe someone's picked off a vessel, it starts to get a bit leaky, so stuff leaks into the blood. The stuff which should be normally inside the cell gets into the outside, and when the cell dies, it breaks down, lots of stuff goes into the outside. So what we're doing when we measure a biomarker is actually saying we want to measure stuff in the blood that's not normally there. Or quite often the case is it might be there in a little bit, but then we measure a whole load of it coming out when we've had a heart attack. So that's how a blood test works. That's true of just about every blood test we do. We measure changes in things which are in the blood. So, what tests do we dig up? Well, we're really going back in time now. The first one was actually Arthur Carman, very nice man from New York, and he invented a test by measuring this stuff, aspartate transaminase, which is found in all muscle and found in heart muscle. And he showed that if you have a heart attack, the AST goes up. Similar thing was done by this chap, Ledoux, did the same thing for this wonderful enzyme, lactate dehydrogenase. And then finally the next one was something which is found in muscle in abundance, creatine kinase, which was first noted to be elevated in a French publication. And the first practical method was developed by a chap called Sidney Rizalki. This is Sidney, he was my mentor when I was first starting out in this field. And this is a demonstration of how the scientific method works. He was taken out to dinner in L'Épée d'Or, and the chap who took him out to dinner said, Sidney, stop complaining about the fact you haven't made any money from the LDH method. You do me a method for measuring CK. And this is it. It's written on the menu card. All right? And that is the method which is still in use today. It's one of the most referenced papers around. So that's proper science, done over a glass of wine. So, cardiac biomarkers and the ECG are therefore now recognised. So here we are. We are in 1979, and the World Health Organization has come out with a definition of what constitutes a heart attack, a myocardial infarction. And you can see we have definite myocardial infarctions if there are ECG changes or unequivocal enzyme changes. And we have possible myocardial infarction. So we sort of reached a point of science now. So, what next? So here's our cardiac timeline, if you like. And it really begins scientifically back in the 50s with Arthur Carman and AST. And so we're basically in the 60s and 70s of diagnosis. And we all know what the 60s and 70s were like. It was all about sex. Heart attacks only occur in men. Drugs. But unfortunately, we didn't have any drugs to treat myocardial infarction, heart attacks. And of course rock and roll, and we all know that the music really only stopped being good in the 80s. Right, so, but times change. The times are changing. Now, Mr. Dillon talked about the times being changes in the 60s, and you'd think, well, maybe the 70s were good, but actually, in fact, when it comes to heart disease, it's the 80s, where things started changing. And I'm pleased to say at St George's Hospital, which is where I work, a pathologist changed the world. This is a pathologist as in I cut people up when they're dead pathologists, right? Which is what most people regard pathologists as doing. It wasn't me. And it was this splendid chap, Michael Davis, who sadly has died of pancreatic cancer. And he did something absolutely amazing. He took a whole bunch of people who had died with heart attacks, and he carefully sectioned their coronary arteries to find out what was going on. And what he was able to show for the first time ever was this. Here we have a coronary artery. It's not a happy coronary artery, it's got lots of stuff on the inside, which we call plaque. And here is a plaque, and it's torn, it's ruptured, and the blood has clotted inside it. It's gone to the lumen of the pipework, if you like, and blocked it off and caused a heart attack. And he was able to demonstrate that there was a mixed. It contained some stuff called platelets, which are part of the blood clotting mechanism, and then it had a fibrin clot. When you cut yourself, the first thing that stops you bleeding to death is the platelets stick on it, and then it clots over. So you'll all remember that when you have a cut, it goes a bit, you bleed a bit, then it sort of goes a bit squishy, and then it sort of seals itself off. And this was a revelation, because basically we're no longer arguing about why people have heart attacks. We now know it's due to blood clots, and it's due to these plaques rupturing, tearing. And this is dramatic, because this is a sort of what happens throughout your life to your arteries. This is you when you were about 1, and we're all of you. If any young person would like to volunteer to be dissected, I will prove this. All of us are going down this direction, that we're getting build-up of this stuff in the walls of our arteries, the so-called atheromatous plaque, and if we are severely unlucky, it will do that. It will rupture, we'll get a blood clot in it, and we will have a heart attack, a coronary thrombosis. And this is earth-shattering. Now, why is it earth-shattering? Because this was a truly paradigm shift in understanding heart disease. Because for the first time, we know that acute plaque rupture is the cause of having a heart attack. We have an understanding that this is something that builds up with time. We have this idea that the first stage of a heart attack is an accumulation of platelets, so-called white thrombus, which then goes on to red thrombus. And because we know what's going on, we then think, well, perhaps we can do something about it. So we start thinking about drugs that will block the action of the platelets, or perhaps block the clotting cascade. And more importantly, from the lab's point of view, it actually meant that we should start thinking about making a diagnosis of heart attacks by using testing in real time. And the traditional role of the lab was basically we would do blood tests over 3 or 4 days, and at the end of 4 days you'd come back and say, yes, we confirm the patient's had a heart attack. And all of a sudden there was a certain amount of pressure on us to say, can we do it more quickly? So we started looking at methods of being a bit faster in diagnosis. And it's very important because it means we go from this model, which is what we used to think happened, and this is what happens to my central heating system model, which is that basically what happens is you get more and more crud in your central heating until it stops working. And this is what people used to think about heart attacks. So it was believed, yes, you do get build up of this stuff and then eventually you have a heart attack. And this is actually totally and utterly completely wrong. Because what we have is this. Here we are, this is us when we're born, and this is pretty much soon thereafter. They do post-mortems on all American servicemen who die in action, which the Americans are very good at providing large number of them. And they've been able to show from Korea onwards, through to Kuwait, that American servicemen already have evidence of this, even the lads in their 18, 19, 20-year-olds. Right? But you can have these, they sit in the walls of the artery, they don't cause any blockage, but if they tear, you get an initial thrombus, and if it propagates, you get a full clot, and that gives you a heart attack. And this explains why 75% of people who come in with heart attacks have no symptoms prior to just wham, I was out shopping when. And of course it means that we can do other things. So, what treatments have we got? Well, actually now we've really moved on dramatically because we know that it's due to clots, we can get rid of them. So the first things that we did was inject clot-busting drugs into people. And this was done basically back in the end of the 80s, thrombolytics trials. And what's really we do now is we do what I like to refer to, any cardiologists in the audience for me to offend? Oh, good. The cardiologists do acute intervention, which is basically a dyno rod. Right? They put a dyno rod down your arteries, but it's a very expensive dyno rod, and then they put in a piece of very, very expensive chicken wire, which is called a stent. All right? And if you think I'm joking and you have a strong stomach, just watch a video clip on YouTube of what they do to your arteries, because you might think you never want to see anyone again. But they do a fabulous job and they save lives. Right? So it is a good. They are good people. Right? You're a good person. So, and this is a transformation, and this has really changed the way we manage heart attacks. All right, so we understand what's going on. We've now got rational treatment. What about the tests, the biomarkers? What's new here? Well, the new thing was the advent of the measurement of cardiac troponin. Now, this is a paper published by Hugo Kattas, a cardiologist in Germany, in Heidelberg, published in a well-known cardiological journal that we all read on a day-by-day basis, the Journal of Molecular and Cellular Cardiology. And this was the first publication on cardiac troponin and using this as a diagnostic test. And this is cardiac troponin T. So what is cardiac troponin? Well, troponin is a protein which is found in the heart. It's totally specific for heart injury, for myocardial injury. Now, this is a good thing and a bad thing because it means that it always goes up in heart attack, but if I was to stab one of you in the heart and then measure your troponin subsequently, it would go up. Right? So it's a fantastic test, but it means it detects cardiac damage, and cardiac damage does not necessarily come only from myocardial infarction. If you get kicked by a horse in the chest, for example, it will bruise your heart and your troponin will go up. A bit of sort of scientific biochemistry stuff. This is a cardiac myofiber. Your heart is made up of lots of these, and if you look at it in detail here, you have this protein, you have these actin balls, you have this troponin-tropomyosin complex, and they have troponin T, which looks a bit like a tadpole, and troponin I. And the proteins that you find in the heart, as opposed to the skeletal muscle, are different. So we can detect absolutely if there's any problem with our heart muscle by using this test. Okay, so we've got this whizzy new test, and we're trying to sell it to the cardiologists. The trouble is that the cardiologists don't believe in blood tests because it takes 3 days, and they believe in the ECG, so we need the Jedi Knights to come in and wield our troponin. So, why did we think troponin was so good? Basically because troponin would predict what happens to people in the future. It is a biochemical test that will tell you that one of these plaques has ruptured and stuff is going off downstream and damaging little bits of heart muscle, and hopefully you can get at it before blockage of the heart occurs. And this was one of the first papers published in this field, together with my sadly deceased colleague Peter Stubbs, who in fact died of a heart attack, thereby demonstrating you die of your own speciality. Very sadly, at a young age. And we were able to show that if you took people who were admitted to hospital with chest pain, and we excluded all ones who were diagnosed as having a heart attack using the conventional tests, but we measured their troponin, we were able to show that if you had an erased troponin, you had a much higher chance of dying from any cause than if your troponin was low, and we followed them up for up to 4 years in some cases. So we were able to show that a small amount of troponin detectable in the blood was bad news, and perhaps we should do something about it. Anyway, there was then a flurry of other tests looking at it, and basically we all came to the conclusion that the great advantage of troponin was that it's completely specific for heart damage. That if you'd use the other tests currently in use, you would find elevated troponin in about a third of people who otherwise were said to be well, and it always predicted a major adverse cardiac event. Now, I don't know about you, but if I have access to a test that would tell me that I might die if I don't have it done, I would really like to have it. And this was followed by a slew of papers over the course of the next decade, confirming that troponin was the test. And more importantly, it showed you if the troponin was present, you should give all these clot-busting drugs, you should take them to the cath lab, you should do all these wonderful interventions we've got, and they worked. But if the troponin wasn't up, they didn't work. And that was really important. So, we've got the 90s. We're now in the 90s. This is the troponin decade, right? So we're into the troponin decade, finishing up with this conference at the end of the 90s, and then troponin conquers Europe, and then it conquers the world. First it conquered Europe. Myocardial infarction is now defined not in terms of other tests, but in terms of troponin, and only troponin. And then it not only conquers the world, it conquers the universe, with the universal definition of myocardial infarction, which says, yeah, it's all due to the troponin. Now, there's a certain amount of refinement as we get more evidence, so we're back to 2018, we're now at the fourth universal definition, so we're working forward. So this is looking good. However, we are victims of our own success. If you go into the emergency department of the hospital and you have pain between your nose and your knee, you will get a troponin done. Right? And we had it's done in trauma. And I recently audited all that we were requesting, and I had to have a word with our trauma team to point out that while I had no objection to them measuring troponin on people that came in with severe trauma, I didn't think a cut finger constituted a risk to your heart. And they did agree to take that out of the trauma definition. And the problem is, there are a large number of causes of troponin elevation where people don't have a heart attack. And this leads to the following interesting scenario.
Hi.
Hi.
Are you the cardiologist on call?
Yes. Who are you?
This is the emergency department.
Sure. What's the story?
There is a troponin. You need to fix it.
Okay. Tell me more.
There is a troponin. You need to fix it.
Can you tell me more?
The troponin is 0.3. You need to fix it.
Okay. Let's start from the basics. Where is the patient?
We moved her to the cath lab. You need to fix it.
Anything else you can tell me?
The troponin belongs to a 97-year-old lady from a nursing home. She is fasted. That is good.
Any comorbidities?
She is otherwise well. Except for
Except for what?
her temperature is 29 degrees
Right.
It's a bit low.
and her pH is 6.8.
Really?
And she has a condition I have not seen before.
Which condition is that?
A systole.
A systole.
A systole.
Right. And you want me to catheterize her?
There is a troponin. You need to fix it.
Why didn't you tell me about it from the start?
I did. There is a troponin. You need to fix it.
No, not the goddamn troponin, the bit about a systole.
Because then you might refuse to catheterize her.
Don't you think I'd have noticed a systole when the patient arrived in the cath lab?
It will not take you long to fix the troponin. You are very skilled with needles and contrast injection.
She is not fit enough for a haircut, let alone in catheterization.
There will be minimal door to balloon time.
I think she has other management priorities at the moment.
Like the troponin.
Like CPR.
They have finished doing that.
Oh. They have stopped doing CPR on someone in a systole.
Yes.
That means she is dead.
There will be minimal blood loss.
You know what? You're right. There is not much blood loss when there's no friggin' cardiac output.
You need to fix the troponin.
Please go away.
You are being obstructive by refusing to do my case.
And you are making my head hurt.
There is a troponin. You need to fix it.
I need to go and run into a brick wall.
If you have chest pain, I will consult cardiology for you.
And you think I'm joking? We get those sort of conversations all the time. Well, perhaps not as extreme as that, but we do have interesting dialogues. My favourite one was when we first introduced troponin at the hospital I was working at originally, which is ironically named the Mayday Hospital. But the head of the emergency department rang me up and said, Paul, we've got this chap who's come in. He's been stabbed in the heart. I said, oh, yes? How interesting. This is the part of the world where people have samurai swords and chop people up. And so I said, oh, yes, he's been stabbed in the heart. I said, oh, right, okay. And he said, well, we've done a troponin. Yes, the troponin's up. Has he had a heart attack? So I said, I understand he's got chest pain because he's been stabbed in the heart, but the 6 inches of cold steel sticking out of his chest might give you a clue as to what's going on. If you stab somebody in the heart, you injure the heart. The troponin goes up. And he said, oh, when you put it like that, you're right. Anyway, they took him they stitched his ventricle up and he survived, I'm pleased to say. Anyway, nowadays we do measure troponin, but we measure troponin using a methodology called high sensitivity. These are so-called high-sensitive troponins, and this is actually where we've arrived at today. And in fact, we're doing a big review in NICE as we speak of high-sensitivity troponin, because this is basically where it's at. And basically, high-sensitivity assays mean we can measure small amounts very reliably, consistently. Anyway, if you want to sort of put this means that our tests for troponin are now more sensitive than every other test going for heart muscle injury. My wife's a radiologist, and I like to point out that we're actually much cleverer in the lab than she is. I usually then run away. She's got short legs, so I get away. And it's been estimated, in fact, if you only have to destroy 40 milligrams of heart muscle to be able to detect a change. Now, to put this in perspective, that's the equivalent of dropping 1 sugar cube into Loch Ness. So we're very, very sensitive. Okay, so what does this mean? What it means is that if you do have the misfortune to go into hospital with an attack of chest pain, and you're sort of thinking, oh God, I'm going to be here for the next day. That's assuming you get past the 4-hour wait, of course. In fact, now we can make the diagnosis using these high sensitivity assays very rapidly indeed, because we can measure the troponin as you come through the door. And if it's really low, we can say actually your chance of having a heart attack is really low, and you can just go straight home, which is great. One and done, they call it. And we can also measure it over very short time frames now, so over 1 to 2 hours. So basically, within 3 hours of getting into hospital, it's now possible for us to make sure that you have either had a heart attack and deal with it, or it'll be absolutely clear to you that you haven't. And I would like to find anyone in the audience who would actually prefer to wait in hospital for 24 hours when they could actually be out in 2. So that's the first big change. So we can do it faster, quicker, better. But interestingly, because we can now measure troponin down to very, very low levels, we can measure it in the apparently healthy people, which is us lot. And this has some interesting sequelae, because it's become apparent that if you measure troponin in populations, these are people who think they're well, and you look at the troponin comparing a level which is a little bit above normal, or maybe even normal, with ones which are very low, you can use it to say that you're at higher risk of dying, or having a heart attack, or developing heart failure. So what we have potentially here is a test that may enable us to look 10 or 15 years downstream and see whether people are at risk for the future and do something about it. And the do something about it is looking quite interesting. This is from a very interesting study by a colleague of mine, Professor Nick Mills up in Edinburgh, where they actually took the blood samples that were drawn in a big study of giving people statins, which are actually wonder drugs or killer drugs if you read the Daily Mail. And what they were able to show in this 5-year study was that what predicted whether you were going to have a high or low risk of heart attack after follow-up was not actually the change in the cholesterol, but actually the change in your troponin. And that if your troponin went down, you had a good outcome, and if your troponin stayed the same or worse went up, you'd have a bad outcome. And this is very suggestive that we may have a new use for these high sensitivity assays, which wasn't there before. Now this is speculation. We're now absolutely at the cutting edge of the present day. So, on that note, what is the future? The future is troponin. Questions? That's a tiger shark, and I photographed it. That's a rather scared diver behind it. That fellow is about 8 foot long and bites.
Thank you, Paul. Before I'd just like to firstly thank you for really what was a really very entertaining and informative talk. Who knew that heart attack could be entertaining? So, questions. There's at least one hand up there. So we've got some microphones so that everyone can hear. So if you can just wait for the microphone to come, Kim. Yeah.
So I'm interested in the kinetics of the release. If the artery is blocked, how does troponin get released actually in the circulation? Does that have an effect? And the second question I have is it conceivable that maybe smaller molecules that are specific in the heart could be released quicker? Or is the size of troponin no issue?
Right. They're two really quite interesting questions. The question of how troponin is released is somewhat vexing in some respects, because in the early stage, when the cell is just a little bit unhappy and is releasing troponin, everyone's been scratching their head about how it gets out because it looks to be too big. But it looks as though what you get is little outpouchings of cell membrane which pop off and then sort of burst and then release the troponin. The other thing that may be going on is a few platelets go whizzing off down to a very small artery and pick off a few cells, and because it's so exquisitely sensitive, we can start to see the rise. The actual troponin itself gets into the lymph and then gets into the blood that way. And the question about can you use other small molecules? Yes, there's a chap down at St Thomas's called Mike Marber who's been looking at another heart-specific protein to see if that will work in a better way. But what he's found is it seems to be perhaps a little faster than troponin, but the trouble is troponin is now established as the gold standard test. If anyone can come up with something that comes out even quicker, this may be useful. But the thing is that we can measure troponin so sensitively now that we can detect changes within 1 to 2 hours. And so there doesn't really seem to be a lot of push to look and find something else because we use it so well.
Can I ask you one more question? Sorry. If the peak of the release would occur after several hours, what is the explanation that the cells which release the biomarker are in the process of dying or already dead and the release process is delayed?
Again, this is there's a little bit of mystery here, because if you look at the kinetics of the release of troponin T and troponin I, they're slightly different. Troponin T can be elevated up to 2 weeks after a heart attack if it's been a big heart attack, and troponin I typically about 5 days. Troponin T has a little peak about 12 hours after admission if the artery is opened and not if it's flat. And when you inject troponin into people, it only stays in the circulation for about 90 minutes. So it's obviously dependent on a continuous release. And if you look at the forms of troponin which are present in the blood over that time frame, they change. In that the first thing that comes out is a complex of troponin T, troponin I, and troponin C, and then it changes and you get truncation of the troponin. So there's a lot of basic science still left to do, because like many things in medicine, we get a test, it works really well, so we just use it, and then we try and work out how it works afterwards. Like treatments, we treat people, well, they don't die, that's good, we'll do that. I wonder how it works. Lady there. You want one of those microphones? Have you seen them? Don't toss them, they're much more fun. Hi.
Hi. I believe that there's a higher proportion of men who present with chest pain with heart attack than women. Is that actually the case? That's something I was taught a while ago. And if so, I was wondering if there's any relationship or correlation with troponins, and if not, is there any sex difference between men and women regarding troponins and myocardial infarction?
Well, you talk to a subject which is dear to me because I am a cardiac feminist, all right? And I'd like to invite you to all become cardiac feminists, because heart disease is relatively underdiagnosed in women. More women die of heart disease than breast cancer, but you don't see much about that in Good Housekeeping or Vogue or whatever you read. And it is an underdiagnosed entity because you are quite correct in that there are more atypical presentations in women. Also, women suffer from a number of other particularly unique complications. There's a condition called spontaneous coronary artery dissection, otherwise known as SCAD, that mimics a myocardial infarction, and you can diagnose with troponin, as with a number of other conditions. So I am encouraging people to be more female aware for heart disease and to treat. And one of the big studies that we did, I was involved with Nick Mills, we showed that in fact women are underdiagnosed and undertreated with things that we actually know work. Now, to come specifically to your point, are men and women different? Well, you'd be amazed to know that they are. And in fact, troponin levels in women are averagely lower. And we have pointed out that you should use a different cutoff for men and women if you're looking at a so-called normal range, and it's lower in women, and it's because they've got smaller physical hearts, but much bigger emotional hearts, as we all know. And so you should use sex-specific cutoffs, and we showed that if you do that, and then you then look at people coming in with suspected heart attacks, you actually level up the number of men and women diagnosed. So it's a very important point, and a very important question.
Thank you.
Hello, I'm David Innes. I'm a member of the general public and not a medical person, but I have some degree of vested interest in this over the last couple of years. When I go to see my GP for my annual MOT, would it be possible and would there be any value in asking for a troponin test?
The answer to your question is probably yes, but we don't yet have the information to be absolutely certain. If you do your troponin and it's sort of above what we consider to be normal, there would be probably some merit in using information like that to decide, for example, should your blood pressure be treated a bit more aggressively? Should your cholesterol be lowered a bit more aggressively? Things like that. But these, at this moment in time, are inferences. All I can say is that I noticed that my troponin had gone up from in my youth, when it was unmeasurable, to one that was towards the upper end of normal, and I actually probably got my GP to increase my antihypertensive medication. But then I'm in a rather privileged position that whenever I ring him up, he says, "Oh, what do you want me to do now?"
I have friends in the right place, though.
It did, actually. It's come down. But that's my series of one. There's a lady at the end there.
Hi, I'm a consultant immunologist, so don't know very much about this, but my question is there a rationale for developing near-patient testing of troponin so that it would be available closer to home rather than waiting for the patient to come to A&E or something?
Again, that's a really very, very interesting question. Now, point-of-care testing for troponin has been around, in fact, for 25 years, and you're speaking to the only person who's ever done any randomized controlled trials. And we were actually able to show on both trials that if you provide point-of-care testing in the hospital setting, you can actually shorten hospital stay, and in fact you can halve it. Originally we showed you could actually go from 4 days to 2 days, and then more recently in the emergency department we showed you can actually get down to about 3 hours rather than 8 hours. So yes. Now the question then comes in, is your point-of-care testing good enough? And at this moment in time, there are only 2 methods for measuring troponin at the point of care which meet the high sensitivity criteria, which I talked about earlier, and they have literally only just been launched. And this means that potentially there's a role for point-of-care testing. The first and most obvious one is if you are talking about a rural healthcare system, where you might have to get a helicopter to be shipped into hospital to have definitive treatment. And it does raise the interesting question that perhaps if it was cheap enough and easy enough, we might be able to use it for self-monitoring. But again, we're not at the point where we can actually say, yes, we know. I mean, at the moment, we know from the evidence that's out there that if you are healthy but have an elevated troponin, you are at higher risk. But all that sort of says to me is, if you're a private patient, you better pay your bill now. We don't know for certain that we should be treating these people or what we should be treating them with. We're absolutely on the cutting edge here now. Fascinating though it is.
Thank you. I wanted to ask you, how robust is the normal range? Really, plays to the cartoon that you showed. So you talk of sex differences for the normal range. What about age differences? What about normal range of ITU patients? What about normal range for a marathon runner?
Yeah.
So how robust is the normal?
Right. You're moving, unfortunately, into the theology of clinical biochemistry here. And this is where we start debating angels on the head of a pin. Also have to be talking to the right person. We did a study about 10 years ago now where we looked at troponin in, I just bleed you all and I look at your troponin. And then I exclude people who are taking pills or have got a medical history. And then what we then went down to is we actually imaged everybody's hearts. So we actually knew who the super normal people were. And you're quite right, when that happens, the upper reference range falls dramatically. And it's sort of supportive evidence for the idea that actually if your troponin's up, there's probably something wrong with you and we maybe should look at you in more detail. So that is certainly the case that if you use a population-based decision, then you've got some issues, and it goes up when you're older. It is said, for example, that the normal range for troponin in a 65-year-old is 30. I don't actually happen to agree. What it means is that sadly your heart is not 18 anymore, or even 25. And my personal belief is that what we've got is we can define a really healthy troponin and say if it's not that, then you need to be looked at, and then you interpret it in the grounds of how old you are, have you run a marathon, etc., etc. The marathon runners are actually quite interesting because they get a little troponin blip after they've run their marathons, and we're not quite sure why, because they clearly aren't having a heart attack. The only comment I would make is that if you want to run a marathon, train first, because if you're an untrained runner, you get a much greater rise than if you're not a trained runner. So there are obviously, there are areas that we're still looking at. But because of the testing strategies which we now do, which is to use an initial troponin, where we have a low level, we can say a level of troponin which is this low means the probability of you having a heart attack is really low as the first stage. And then what we do is we do a second measurement if we're not sure and look for a change. What we're doing is actually moving the testing from away from a range to actually individualising it to the patient. Because the problem with troponin, or the good thing, bad thing with troponin, is that variability within one individual is quite small, but across the population is quite large. And this is something which we see with a lot of tests, and what it says is, if you've got a large variability in your test, then you're much better to use the individual as their own reference point. And what we really want to know with the troponin is, are we looking at an acute injury that we need to do something about, or is it just how you happen to be? So what I say to someone is, you come into the hospital, you do their first troponin, and we'll say it's double normal. That doesn't mean they've had a heart attack. That means that something going on. And then you do a second one. And if you go rocketing up, you say, right, you've got an acute injury, we need you in, we need to look at you, find out what this is going on. But again, this might not necessarily be a heart attack. A little story. Anecdotes are always good fun. But a terribly nice gentleman came into our well-known Centre of Excellence, and he'd actually got up to change the channel on his television, which of course is not something that people tend to do these days, but very nice man, retired stockbroker. Anyway, he got up, got a bit dizzy, fell over and cut his head. So we came into hospital, and being smart physicians, they noticed he'd got a cut head. So he stitched his head up. Good. Some person decided to send off a troponin. Anyway, this gentleman actually had a rhythm problem with his heart. He had something called atrial fibrillation. And this is known to put the troponin up a little bit. And the result came back, oh, look, his troponin's up. Whereupon this person, who I would cheerfully like to throttle, decided to give him all these, these drugs that reduce your clotting. And needless to say, he had a big bleed into his head and da-di-da. And that was because they just looked at the troponin and didn't look at the patient, and more importantly, they didn't actually measure it serially. So, tests are only as good as the people that do them. And what I keep trying to hammer into everybody is, you've got a person sitting in front of you. If I could replace some of our doctors with scans and blood tests, I would cheerfully do so, but sadly, I can't do it yet.
Some more questions at the back there.
Thank you very much for the talk. You mentioned just now atrial fibrillation.
Yeah.
And I was thinking that one of the things that I've come across in my GP practice is that if there's any suspicion of this, they do ECGs. Rather than doing it at the same time as the blood test, and I have no idea whether the blood test troponin. So what is the relationship between ECGs, atrial fibrillation, and the troponin you're talking about?
I think this is it's not been looked at in any detail, so I'm going to speculate. Basically, what you have with the troponin is you could have troponin up in someone with atrial fibrillation because the actual atrial fibrillation is impairing to some extent the blood supply to the heart in those areas which are in the so-called watershed between where two vascular beds are. So you've got a few of these not very happy heart cells kicking a bit of troponin up as a way of, hey, we're here, we don't like this. Or it could just reflect how the person's general health. So you've got sort of two possibilities, but I wouldn't encourage you to start measuring troponin on all your atrial fibrillation patients. Please.
Another question there.
Unless you're doing it privately and I'm running a private lab. Then you can do whatever you want. No analysation without remuneration.
I'm a biomedical student, so biomedical genetics student, so I'm saying it more lean towards clinical genetics and the genetic variant towards like CTN levels. Do you think that with the global the distribution of variants towards the risk of AMIs would affect the CNT levels?
So, what you're saying is how much of it is genetic?
Yes.
Right. I'll just so we both understand. I don't think troponin is intrinsically genetic, if you like. There have been studies that look at different ethnic populations, and the troponins seem to be pretty much the same. But it's not something which has been done in massive detail, because the trouble is, in order to do the so-called reference populations, you need a minimum of 300 individuals, and it's difficult enough to get 300 individuals of a particular age, let alone recruiting them from every ethnic minority. But I don't think there's likely to be a difference. But I can't put my hand on my heart and say for certain.
Question.
Hello, mine's a bit of a diving question related to troponin. My husband went to hospital after surfacing quite quickly from diving. It was mainly around the fact he had gone up too quickly, so he'd gone into hospital, but actually when he was there, they kept him in because he thought potentially he was having a heart attack because he had raised troponin levels. As it was, he was absolutely fine, but I was just wondering whether sort of diving, which I'm assuming does put quite a strain on your heart, would potentially raise troponin levels.
Oh, that's a good one. I wonder if I can get a research grant for that one. Result. Basically, anything that you do to your heart which upsets it can result in a troponin rise. I mean, the $64,000 question with him would be, was this a little rise and fall, or did they just find that his troponin was up a bit and remained up a bit? Yeah, that would suggest to me this baseline troponin is a bit on the high side. And have you increased his life assurance? But certainly I think you need to encourage him maybe to look after his make sure his blood pressure's down, is eating healthily, or cholesterol, or I mean, alternatively, if you want to keep him around.
The gentleman at the back there.
Just taking back to the AF question, the raised troponin. I know with AF that quite often they give blood thinners, whether it be warfarin or apixaban. I was just wondering whether that would help mitigate the risk.
Giving the blood thinning drugs is all about stopping people getting clots in the atrium, which is where, because there's a thing called the left atrial appendage, which is a sort of redundant bit of heart, and you get a blood clot in there. If the blood clot goes from there somewhere else, if you're lucky it will go down, and maybe just your toe drops off, but if you're unlucky it goes into your head, and your head drops off, which is not good. And so, from the point of view of the cardiac risk, that's what the blood thinners there are all about. It's not really troponin related.
Into the middle at the front here.
Can you shout then?
Shout. Yes, I'm not a doctor and I'm not a researcher. I'm a person who's had a heart attack.
You're one of the people I'm out to save.
Yes, well, thank you for everything you've done, because so far so good. But I'm very concerned that there seems to be no way, and I don't really understand whether troponin is the answer, but I now, of course, want to know, are my arteries becoming clogged up, or is an artery becoming clogged up, without my experiencing any symptoms? And I'm told, no, you can't have a regular angiogram, no, you can't, there's another, all cost too much, and it's invasive, and this sort of thing.
It's because you know radiation, that's the other thing.
Yeah. But I do know that I have an angiogram, people can tell, and I don't know whether it's possible to have scans which can tell. How can I tell whether or not, how can anyone else help me tell whether there's something going wrong? Because I just feel I'm living here and I just don't know.
Right. I mean, you're not alone in and that my clinical practice, in fact, is in prevention and management of dyslipidemia and seeing people post-heart attack. I get that question fairly regularly. The problem is that what we actually need is the Star Trek tricorder, and no one has obligingly invented that just yet. So we have to make do with what we've got. And the problem with the imaging tests is, although they're very, very good, they're not perfect, and they still involve a load of radiation. So the thing which I say to everybody is that what you do is you do all the things that we know work. So you make sure you're under ACE inhibitor, you make sure your cholesterol is right down, and you take your aspirin or ticagrelor or whatever it is they put you on to keep going. And beyond that, at this moment in time, there really isn't anything else. But this is an area where I think, actually, the troponin might be helpful. Because if you serially monitor the troponins and you find that they're drifting up, I think it's likely that something else might be worth doing. But again, as I said, this is, at this moment in time, it's the purest speculation, because we need people to do studies to look at it. And obviously on a personal basis, you think, well, am I going to have a problem? Well, if you're doing all that you're doing, you just then have to play the odds. I can't really advise you on that. I mean, it's not. I always put it in the phrase, what would I do? You know, what would I do if it was me? If it was me, I wouldn't be going and having regular CT angiograms. Because all that's likely is I might cook my heart with radiation and make things worse rather than better. I would just take my pills and do all the things I should do. Exercise, etc., etc. Yes?
I was a nurse in cardiology in the 90s. I was a nurse in cardiology in the 90s, and people were talking about cine MRI and possibly cine CT scans, but that never seemed to went anywhere. But do you think that might help the lady behind me? There's no nasty dyes or anything to mess with?
Yeah, I mean, the CT scanning technology has actually improved dramatically. Funnily enough, I was discussing this with one of our radiologists a couple of days ago, and I was supposed to be giving a talk in Vienna, but I sadly can't now because they postponed it due to the dreaded Chinese killer virus. Sorry, COVID-19 it's called. It is possible that within the next 5 or 6 years they will get the technology such that they can routinely monitor people's coronary arteries non-invasively. The problem there is basically comes down to the money. You know, we haven't got enough of everything at the minute, and if you then start stacking a load of other stuff on top of it, it's problematic. So you need a tricord. Young people in the audience, invent a tricord.
So perhaps one final question. We've been working very hard. There's one gentleman here at the front. So
going back to your before measuring heart attacks, what does troponin actually do?
Troponin is a regulator. Basically, the troponin-tropomyosin complex is the switch that runs heart contraction. When a nerve impulse arises at the heart, it's obligingly distributed all around the heart, so that the heart contracts in one go from the bottom up, because it's a squeezy pump rather than a round and round pump. And you get a release of calcium into the cell, and it binds to the troponin C, which is the bit which is found in all sorts of muscle. And this causes the whole complex to shift away from the fibres underneath and causes them to contract. Now, obviously, you want that to only to happen and then unhappen, and then the calcium goes out, the thing flips back, and it undoes again. So it's the switch, it's the contraction switch. And it's running in your heart at anything up to 180 times a minute. Hopefully well.
thank you. So I'd like to then draw this evening's lecture then to a close, and I'd just like to ask you to thank Paul again for a really entertaining